Good morning, everyone, and welcome to the latest webinar of the World Federation of Neurorehabilitation. Today's webinar is brought to you by the Botulinum Toxins and Spasticity Special Interest Group that I have the pleasure of co-chairing with my colleague, Professor Jorge Hernandez Franco. The Botulinum Toxins and Spasticity SIG was established with the intent of enhancing educational activities and promoting evidence-based application of botulinum toxin therapy and neurorehabilitation, including spasticity. We also want to identify knowledge gaps in botulinum toxin management of various neurologic conditions, ranging from spasticity to movement disorders and others, through the critical appraisal of scientific literature and disseminate information on the current state of the application of botulinum toxin therapy in neurorehabilitation. If you're interested in learning more about
Thank you, Professor Gerard Francisco. Good morning, everyone from Mexico City. For me, it's a pleasure to introduce our speaker, Professor Sheng Li. Professor Sheng Li is a professor and director of stroke recovery and rehabilitation research in the Department of Physical Medicine and Rehabilitation at UT Health McGovern Medical School. He's board certified in PMR and brain injury medicine. Professor Li's clinical focus is in neurorehabilitation and spasticity management. He takes a comprehensive approach for spasticity management, including modalities, botulinum toxin, injections, phenol, and cryoneurolysis, and baclofen pump management. Professor Li's research interests are pathophysiology and management of spasticity and disorder motor control and motor recovery after stroke and neuromodulation. His research has been supported by the National Institute on Disability, Independent Living and Rehabilitation Research, as well as National Institutes of Health and Foundation grants. He has published more than 140 peer-reviewed journal articles. So please, Professor Sheng Li, could you please share with us your lecture? Thank you very much.
Thank you, Professor Francisco and Professor Franco, for the invitation and the introduction. Today, I would like to share my experience on neurolysis for spasticity management update using phenol neurolysis and cryoneurolysis. I know this is the botulinum toxin and botulinum toxin special interest group. But as we know, spasticity management has a range of interventions, including modality, toxin, nerve blocker with phenol and cryo and surgery and baclofen pump. So today I will cover the neurolysis. We'll bring you some updates specifically on phenol neurolysis, and we'll cover the new development in using cryoneurolysis. So here is my disclosure. So as I mentioned, we'll provide some updates on phenol neurolysis, and we'll also cover new development on cryoneurolysis, and at the end, I will will compare these two interventions for nerve block. So phenol neurolysis is not new. It was the primary intervention or procedures we do to manage spasticity back in 1960s and 70s and even 80s. And when botulinum toxins therapy came on board starting 1990s and onwards, and the clinical use of phenol neurolysis has gradually decreased. However, in the recent years, with the advances in technology, especially with ultrasound-guided injection, and its use has been revived and expanded. So I will but as of now, phenol neurolysis is not FDA approved for spasticity management yet, and there's a clinical trial on this application. The study is ongoing. So first question, how does phenol work? The phenol has two mechanisms of action. First, it will cause the immediate effect through acute demyelination, and which is followed by a non-selective denaturation of protein of nerve fibers of all sizes. That means we have to localize these targets very precisely. And this phenol injection can be performed at different levels, at the nerve trunk level, branch level, and the intramuscular motor points level. According to prior animal studies, and after phenol injection and the nerve, there are near complete regeneration of peripheral nerves, as well as muscles and muscle fibers. So phenol has immediate onset effect, as shown here. Immediately after phenol injection to musculocutaneous nerve, we see the immediate increase in range of motion of the left elbow joint. And 2 weeks later, we see the further improvement in the resting angle of the elbow joint on the left side. So if we take this measurement and plot over time, as we can see here, as compared to the baseline pre-injection, we see there's an increase in resting angle immediately, and a further increase in about 7 days in this study. So, and the immediate increase in range of motion is about 58.7% of the max increase, and it's about 60% of the peak effect. And this effect occurs about 1 week or 2 weeks, depending on the subjects in our study. So now we know that I usually tell my patients we see the immediate effect, and you will have further improvement in a week or so with 40% more. So for the concentration, we usually use 5 to 7% phenol concentration for neurolytic purposes, and we have usually heard there's a dose-dependent effect of the phenol neurolysis. However, I wanted to point out here that this is based on the animal study, and we please pay attention to here that the dose was very low, is only 0.1, 0.2, 0.3. As later I will show you how we use clinically, it's much higher dose than what is used here. I would say we use this concept with caution, that we may have a ceiling effect if we use a higher dose. So how much phenol is allowed for each procedure? So as a rough guideline, so with a perfect lethal dose in adults, it's about 8.5 grams. I usually will not go beyond 20 ml, 6% phenol, which is equivalent to 1.2 grams. This is far below the lethal dose and have not got any systematic side effects in my practice. So systematic side effects include cardiovascular failure or severe central nervous system dysfunction, i.e. seizure. So usually the first sign of systematic reaction of overdosing is a metallic taste. And one patient told me she felt a taste of dead fish. So if the patient tastes something weird, it's a sign that we need to stop there for the day. But I also have the patients did not tolerate the pheno injection for the first time and stop at 9 ml, but in the next round, he was able to tolerate more, up to 15, 16 ml. So how long does the effect last? As shown here, it's all over the place depending on the procedure was performed. For example, there's a range anywhere from 10 days to 6 months, from intramuscular and peripheral nerve block to open nerve block. And there's a few factors we need to consider, for example, the concentration, dose, localization as listed here. However, based on my experience, I think the precise localization is the #1 factor that determines the outcome. And this is related to the mechanism of action I mentioned earlier, which is because the pheno will cause non-selective denaturation of protein. So if we cannot deliver the pheno to the target, which is a nerve or nerve branch, then we cannot cause any significant effect. So that, in my opinion, and practice, localization is the #1 factor. So any side effects from pheno? There's two types of side effects. The first one is procedure specific, related to the needle. For example, pain from the needle or some of the bleeding from the needle insertion. The other is pheno-specific side effects. First is nerve block may cause the weakness, and we need to be cautious about this side effect, especially for if we want to block in the lower extremity, in those patients with weight bearing or is able to walk and to do the is ambulating. So if we block too much of the femoral nerve, will cause the quads weakness, the patient may not be able to walk. Also in the upper extremity, if the patient is able to move and open the hands, and if we block it, the weakness may cause loss of voluntary action. So, and the other phenospecific is the sensory side effect. It may cause the temporary sensory loss, or may cause a dysesthesia, where this is the most worrisome side effect, because this may cause the neuropathic pain, and it may last several weeks. However, I needed to point out here that the neuropathic pain or dysesthesia after phenoneurolysis does not occur immediately. The onset is likely to be delayed by a few days to 2 weeks. And the treatment is to repeat injection or to prescribe some oral nerve pain medication such as gabapentin and Lyrica. And in this case, if this does occur, patients usually are not likely to accept a repeated injection because it causes the problem in the first place. So here is the general setting I used in my practice. There's a different guidance. Use the electrical stimulation guidance and ultrasound guidance. I would recommend use the combined both ultrasound imaging and electrostimulation guidance. At the tier where I practice, and we can block, this is a list of the nerve and nerve branches we use a pheno for. As from the list, you can see we block pretty much from head to toe all peripheral nerves. And about 6-7 years ago, we did a chart review to summarize our experience, and we reviewed 185 patient charts, and with 293 procedures for these patients. And there's a different guidance was used, the E-stim only, ultrasound only, or combined ultrasound and E-stim, and the majority of the procedure were performed under E-stim and ultrasound guidance. And for the dose for each procedure is about 10 ml. It ranges from 1 to 30 depending on the number of nerves. And the pheno dose per nerve on average is 3.5 ml, but it ranges from 0.75 to 18 ml. So there's a large variations. So the outcome from our review, we can see overall with more than 95% of the procedures, there's no adverse effects. And there's a 3.7 or less than 4% of the procedures causes some prolonged pain. And this seizure only occurred in 2 procedures out of almost 300 procedures. And for the nerves, and the phenoneurolysis to tibial nerve and its branches causes the most side effects in 11 procedures, but there's a few side effects in other nerves. So now I will move to the clinical applications of phenoneurolysis, as we are usually taught through our resident training. Pheno is reserved for most proximal muscle groups and big muscle groups in those with severe spasticity. So here's one example. So this is a 25-year-old TBI patients was admitted to tier 15 months after the accident. Even he was on mega dose of medication, like 30 milligram of tizanidine and 100 milligram baclofen. He had still had very severe spasticity and abnormal posture. On the next day after admission, and I performed the pheno injection to the lower extremity for hygiene and positioning purposes. And we can see his legs was much better positioned and rested. And after casting, patient can be comfortably positioned in the wheelchair. And after botulinum toxin to the upper extremity and a further implantation of the pheno, patient can be comfortably positioned in the wheelchair, even without cast. So this case also signifies the importance of combined use of all available interventions for the best clinical outcome. So here's another case, patient with equinovarus abnormality in a patient with severe spasticity after TBI. And as you can see here, after almost 2 weeks after pheno injection to peroneal nerve motor branch and the tibial nerve motor branch, and the abnormal position has been corrected. So with the combined use of ultrasound and e-stim guidance, the application of phenoneurolysis has been expanded to more in the distal upper extremity. As we can see here, let me see. So I was performing the phenoneurolysis to the radial nerve branch to wrist extensors. And with the ultrasound guidance, and it's easier for me to localize relatively where the nerve branch is located. And with the e-stim guidance, I can confirm the location with the wrist extension response. And here is the outcome after this procedure. So we did another charter review focusing on the phenoneurolysis application in the distal upper extremity, and we summarized from chart 57 patient charts and 102 procedures, and we find that there's overall 1.8 ml per nerve or nerve branch, ranged from 0.5 to 9 ml. It's less than from the other part of the body. And we follow up of the patient. For inpatient, we follow up about 40 days on average. And for outpatient, we follow up about 90 days. There are only 3 cases out of this group, about 3% with prolonged pain, and no other adverse event was found in our chart review. In other words, relatively speaking, it is safe to use phenoneurolysis for management of spasticity in the distal upper extremity. So not only we expanded use of pheno injection more than just the severe spasticity, and we've used it for those with voluntary motor control. As shown in this case, this is a stroke patient complaining of left shoulder waning during walking, but as you can see here, after phenoneurolysis to left muscular cutaneous branch, and her walking is much better, no more chicken winging of the left arm. And as we know, there's a big concern, as I mentioned earlier, is a pheno block will also cause muscle weakness. So in this patient, her elbow flexor is weaker, but however, she still remains some ability to voluntarily flex her left elbow after the procedure. So another clinically relevant and important question is how early can we use pheno to manage spasticity? This is important that especially for inpatient. So we did use pheno for our inpatient and in the early phase, and we reviewed the chart for the especially for stroke patients. There's over 5 years, there are about more than 2,000 stroke admissions at a tier, and we performed phenoneurolysis in 68 patients. within 15 months after first ever stroke. And we know that more than half of the these patients receive the FeNO within 3 months after stroke. The earliest is 19 days. And as compared to botulinum toxin injection, if we did a FeNO injection early, the second round, the patient received much less botulinum toxin for repeated injection. And no side effects were observed if we inject earlier in this chart review. So for now FeNO does require procedure skills, is more difficult than botulinum toxin injection. However, with advanced and combined use of ultrasound and e-stim and advanced knowledge, I think this is doable. Now, in this video shows that Dr. Nathan Dargy, when he was a resident, he did this procedure with me. He did FeNO block to the median nerve branches to finger flexor, and we can see he can find the nerve branch did the isolated finger flexor response under the ultrasound and e-stim guidance, and here shows the good outcome. And this video shows the former brain injury fellow, Dr. Ebony Reed, did a FeNO block to tibial nerve motor branch to toe flexors. And we can see in this patient got good outcome. And on the right, patient has toe curling during walking, but on the right, and this has been significantly improved. So now move on to the new development of cryoneurolysis. Cryoneurolysis is FDA approved for pain management only, and current clinical use in my practice is used for pain management associated with spasticity. And there is a clinical trial is coming for FDA approval for this purpose. So cryotherapy is not, we are familiar with cryotherapy. For example, we got an ice pack when we get the sprained ankle or knee pain after running. And so what cryoneurolysis does is use advanced technology to create a very focal low temperature directly onto the nerve. So to block the nerve, to cause to reduce the pain and reduce spasticity. So in the back in the old days, there's the cryo system is complicated as shown here. This is tethered cryo system and requires a specially designed procedure room. However, with the advances in technology, the whole entire system is condensed into a portable device. This iovera handheld device is very convenient for us to perform cryoneurolysis in almost everywhere. So this figure shows how cryoneurolysis is performed. As is shown here, the low temperature and high pressure nitrous oxide gas is flowing through to the tip of the probe here and flow back to the system. And at the tip of the probe, because of the temperature, it draws the fluid from the surrounding tissue to the tip and to form the ice ball. And because the ice ball with the technology, they can control the temperature at negative 88 degrees Celsius. So that's the reason why they can cause the nerve block. So now there's a different generations of cryoneurolysis system as compared to the old device system. We see the probe or the needle itself is large as compared to the newer one, and the ice ball it generates is relatively small as compared to this newer one. And this is a picture provided from by Dr. Paul Winston. This is the actual picture he took from the clinical practice, and this is the ultrasound image during the procedure. Now, because the ice ball with the cryoneurolysis system can control the temperature at negative 88 degrees, it causes the reversible second-degree axonomesis and causes the nerve block. So there's one important feature I want to mention is that the ice ball does not interfere with the blood flow in the area. So that means the circulation is intact, and when the ice ball is formed and the no further gas flow, and the temperature generated from the circulation can melt the ice ball, and then we can stop the treatment and we can take the probe out. So here is, since this is a relatively new procedure, and I will show how this procedure
treatment of the musculocutaneous nerve
and
to the
this is
bicep
provided
of
by
pain associated with spasticity.
Iovera.
The patient should be positioned supine with slight supination of the forearm and abduction of the shoulder to gain scanning access to the medial side of the upper extremity, just below the axilla, with consideration of the ideal handpiece orientation greater than 45 degrees from the ground. Perform a sterile skin prep. Scanning along the medial side of the upper extremity with ultrasound will demonstrate from anterior to posterior the biceps muscle, the musculocutaneous nerve, the coracobrachialis muscle, the brachial artery and vein, with the humerus located directly lateral. Mark the intended insertion point on the skin. Inject a small local anesthetic wheel for patient comfort, avoiding injection too close to the target nerve, which could cause a false positive result. Place the catheter in the intended smart tip trajectory. Insert the smart tip 2190 with nerve stem attached to the catheter and position the tip slightly beyond the target nerve to elicit a stim response. The stim location is consistent with smart tip cooling center. Therefore, it should be centered on the intended nerve. Press and release the button to start the cycle. There will be an audible tone and a check mark to indicate the completion of the treatment cycle. If desired, reposition the smart tip and perform an additional cycle. Iovera by Pacira Iovera treatment.
So I did my first case last year in December with using this the neurolysis case, and our medical school was posted this news on the social media since we did the first case use this generation of the device for pain associated with spasticity. So I will, in the next several minutes, I will show a few cases I did with cryoneurolysis. And so this is a stroke patient with a right spastic hemi. Oh. And here's the post.
Yeah. Okay.
Let me see whether this can, oh, yeah, this is better. No. Okay, the video is a little slow. Okay, hopefully the next case will be better. So this is another case I did of cryoneurolysis. She had severe TBI 7 years ago, and received multiple rounds of pheno and botulinum toxin injection to the upper extremities, still with a severe spasticity and very limited range of motion for hygiene. And here's the case after the procedure.
Wow. That's amazing. Really great.
So this is a stroke patient about 4 years out. Her main complaint is the left shoulder abduction during walking, and as well as a left elbow flexion. So I did cryoneurolysis to supraspinatus nerve. And here's the post-procedure
Walk.
video.
Yes. Come back. Walk. Yes. Come back. Walk. Yes. Come back.
Okay. So, so cryoneurolysis for treatment of spasticity is still in early stage. There's Dr. Paul Winston and his group in Canada did most of the cases so far. And he published, summarized his experience and published in American Journal of Pulmonary about 2 weeks ago of his experience, summarized the side effects from. So he reviewed the charts from 113 patients, and 277 nerves were blocked with a cryoneurolysis. Overall, it was very safe. A total of 96.75 of the nerve treatments had no pain or dysesthesia beyond treatment, and only a few cases had pain or numbness beyond 3 months. So overall, it's safe. So now compare the pheno and cryoneurolysis. So I really like the term Dr. Michael Munin used. So he said the cryoneurolysis is a green pheno, which means it's green, and we do not inject anything only cause the ice ball, and when ice ball is melted, we take it out. So in general, pheno and cryoneurolysis both have very similar treatment profile, get immediate effect, long lasting, and at least more than 3 months, usually at a range between anywhere for 5 to 10 months. And both are not FDA approved yet, but there's a study ongoing. The risk pheno has more side effects as compared to cryoneurolysis at this time, and both are more affordable than botulinum toxin. Of course, we need to get the general contraindications to the cryotherapy, as the system these are the factors listed here. So if you are interested to look into the further details about cryoneurolysis and phenoneurolysis, I will recommend you look into the recent article I co-authored with Dr. Paul Winston and Dr. Manuel Mas in the Spasticity Management Beyond Botulinum Toxin. Is now in print. Okay, I will turn this to Professor Francisco.
Thank you so much, Professor Lee. Before we move on to the question and answer portion that Professor Franco will facilitate, I just want to put the plug. The World Congress of Neurorehabilitation is going to be held in Vancouver, Canada next May. And I just want to call your attention. There are 2 workshop and symposium on the topic of spasticity and botulinum toxins. There will be I think this is going to be a 2-hour workshop on May 22nd, using ultrasound in spasticity management, not just for guidance for injection, but also for the assessment of muscle architectural changes that may influence the treatment decision making. And on the 25th, at the last day of the symposium, we're going to have a provocative session tackling the controversial topic regarding spasticity and its overlap with movement disorders and other conditions. So we hope that you will participate at this Congress and that we will see many of you in Vancouver. I'd like to turn this over now to Professor Franco to facilitate the open forum.
Thank you, Professor Gerard. Thank you, Professor Sheng Li, for this very clear presentation. So I'll move on now to the questions. We have several questions. The first one, Professor Sheng Li, is what is the cause of post-phenol dysesthesia and how can we prevent it?
So the cause of the dysesthesia after phenol is most likely due to the block of the sensory nerve or the mixed nerve. So how we can avoid it is that we we mainly target to motor branches, not to avoid block mixed nerve.
Okay. The next question is regarding the patient that you show that with the phenol blocks that was hospitalized. With the first patient, what peripheral nerve block was done in the lower limb?
Oh, I did a bilateral obturator nerves and sciatic nerves, and to increase the hip abduction and knee extension.
Okay. The next question is in regard to literature references in regard to the best solo localization of motor nerve branches. Which literature would you recommend? A book, a guide?
Oh, I think recently, there's one book that is editors are Dr. Paul Winston and his colleague is called ultrasound guided nerve for in procedures for nerve block. I believe this
Yes,
is published this year.
yes, and you can actually buy it via Amazon, I guess. I bought it via Amazon,
Oh
so
yeah.
it's a good recommendation.
Mhm.
Okay, the next question is from Mirko Filippetti. In a reinjection of the same trunk, sorry,
Which one? I'm sorry.
in a reinjection of the same trunk, you use the same place or there is a need to change a little the position due to fibrosis to achieve the same effects with the same dose?
Oh, okay. So there's a different perspective on this. So to phenolneurolysis is likely to cause fibrosis around the site where it was initially injected. So yes, and I usually do to repeat injection more distally from the initial one. Now, the other aspect of approach is even for the first injection, if I usually injection the two sites that is very close to each other, the purpose is to increase the duration of the effect, because if we put these two block nearby, and will cause more of the damage or block of the nerve, so it will take a longer time to regenerate and to cover the gap. So if we block two sites nearby, and it will increase the range of treatment effect.
Thank you. The next question is in regard to myositis pain. It says, knowing the risk of muscle necrosis with subsequent myositis pain, do you still perform intramuscular phenol injection, or would you recommend nerve phenol neurolysis for spasticity?
So if I understand correctly, the question is regarding whether we need to do the nerve branch or intramuscular.
Right.
Okay.
Right.
So I personally will prefer to the nerve branches for in general. So because the nerve branches will innervate a larger area of the muscle within for a specific muscle, or it may innervate a group of muscles. So it makes the phenolneurolysis more powerful, or cryoneurolysis is the same way. However, in some cases, we need to block only to take away some of the tone while reserve the muscle strength. In that case, I will do the intramuscular multipoint block to better control the amount of tone we want to take it off, and to preserve the muscle strength.
Okay. This is an interesting question. Is phenolysis and/or cryolysis indicated for pediatric patients with severe spasticity?
Oh, at this time, I think both pheno or cryoneurolysis are not FDA approved yet. So the pheno was used since the 1960s, and the cryo is currently only approved for pain. So there's a new ongoing clinical trials to seek FDA approval for indication of spasticity management. So in short answer is no, but the new studies are coming for FDA approval.
So, and the next question is the big question. How do you choose between botulinum toxin and phenol cryoneurolysis?
Um, there's a few. So I will share my perspective. Of course, different people have a different perspective. For me, the pheno is more powerful, so it can be reserved or is generally used for those with severe spasticity or for proximal muscles, the larger muscles, then they can use. It will take a lot of toxins. And I also will prefer to use pheno for inpatients because the length of stay is short and we wanted to really control the tone as fast as possible. So pheno has immediate effect, and Botox, botulinum toxin will take at least 2 weeks to reach its peak. So, but also from the other perspective, the pheno may cause some of unwanted side effects and may not be able to do these very precise control for small muscles. For in some cases, for example, the pheno we do not use pheno for the cervical dystonia or in these areas. So I think we'll reserve this with most severe big muscles for with pheno and use those who with areas needs precise control for botulinum toxins.
Okay. There's a question regarding differentiating contracture from spasticity, and it says in patients with chronic strokes presenting with severe spasticity and reduced range of motion, do you usually nerve blocks to differentiate contracture from spasticity?
I think in this case, diagnostic nerve block will be the best way to differentiate contracture from spasticity. Yeah.
Okay.
I would recommend to use if there's a doubt.
Okay. There's another question regarding the timing for the lysis, for the neurolysis. The range of timing for each nerve or branch with cryoneurolysis is already set in the device or is based on each PMR experience?
The range of, I'm sorry, the range of what?
Timing.
Timing.
Timing for each nerve. Yeah. It says maybe the person would like to know if there's a sequence regarding the nerves that you are blocking.
Oh, so I
Maybe I
think,
understand it from proximal to distal, or regarding the symptoms of the patients. What is the spasticity? How is this expressing in each patient? Maybe.
yeah, I think it depends on the patient. There's no particular set of sequences we needed to perform. For example, sometimes I only perform the most proximal, for example, obturator nerve for hip adductions. Sometimes I will perform the phenoneurolysis to finger flexors. So it depends on how patient presents to us.
There's a the comment on that question. Mirko Filippiti says, "No, I mean the second for each procedure. The second. I mean maybe the timing.
Oh, the duration
Maybe,
of, okay.
maybe yes. Yeah.
Oh, so there's for phenoneurolysis, I do not use the not depending on the time, depending on the how precise we can localize the nerve or nerve branches. So this is confirmed, I just inject pheno to the nerve branches. And for cryoneurolysis, there's a preset duration of each cycle, which is 106 seconds for one cycle, and it takes about 61 seconds to form the ice ball, and it takes 45 seconds to melt the ice ball. And now the cycles per nerve for cryoneurolysis is depending on the physician's experience and perspective. I usually use 2 to 3 cycles to make sure the patient receive the adequate block.
Thank you. Another question is that provided you have access to ultrasound and electrical stimulation, would phenol use be safe in community settings?
Based on my experience of more than the phenol injections to more than 3,000 patients, I think it's safe given the fact that all the side effects I mentioned earlier. Yeah, I do not see any problem that performing phenoneurolysis in a community setting.
Okay. Do you also use alcohol for nerve blocks? Would you prefer using phenol more than alcohol for nerve blocks?
I did use alcohol for nerve blocks when we ran out of phenol. So I have very limited experience with alcohol, so I cannot comment which I prefer to use. But what I heard is alcohol neurolysis is more painful than phenol and may cause some more side effects. But I do not have first-hand experience, so I cannot comment on that.
Okay, the next question concentrates on amount of phenol and concentration. So the first part of the question is, what concentration and maximum amount of phenol would you recommend to be used in one setting? In one sitting, sorry, in one sitting. Just the first part one.
Yeah, so for the concentration, I think it's commonly used is a 5% to 7% for neurolytic purposes. We use 6% at our facility.
And the second part of the question, sorry, yes.
The second part is the dosing, how much is the max. So so the lethal dose for adults is about 8.5 gram. So I use the 20 ml is the limit for me for the first time to perform phenol injections in an adult. The 20 ml 6% phenol is equivalent to 1.2 gram, and that's far below the lethal dose. And also I will monitor the systematic reaction to phenol. But the common question I ask is, how's your taste? Do you taste anything different or something weird in your mouth? The first sign of systematic overdosing is weird taste, metallic taste, fish taste, all kind of weird taste.
Okay, so the last question is in regard to what your comment. It says, is this in regard to metallic taste, and it's the warning for a toxicity sign. So would you withdraw from performing phenol neurolysis in patients with disorders of consciousness who cannot communicate the symptom?
Mm-hmm. Oh yeah, that's a good question. So in those with DOC, we cannot do. So I will go by the general guidance is at 20 ml, and I have injected like more than 100, at least more than 100 patient DOC patients. Some of the patients received close to 20 ml and has no issues. So
Okay.
I will not say this is definitely safe. I will use this as my reference. But I, of course, will monitor in DOC patients. Will always a good idea to monitor the vital signs, any other the possible side effects.
Okay, so there are no more questions, but I have one question to both of you, Professor Gerard Francisco and you, Professor Sheng Li. This is a very interesting area, a new area for our residents and the students. And this, do you have in mind like the project of uh, developing a school for foreigners to get the training for cryoneurolysis in the US? Because we know Paul Winston has this a possibility to have some students from abroad. But do you foresee having this project in your setting, in your facility?
I will answer that question. So there are conversations
Okay.
this. Of course, this is inspired and that's going to be most likely patterned after Paul Winston's very successful training program in Canada. So more to come. So hopefully, when you all attend the World Congress of Neuro Rehab in Vancouver, we will have some updates for you.
Okay, thank you very much. Thank you very much, Professor Shengli, for this very clear presentation. And I will hand it to Professor Volker Humbert to wrap it up and to close this webinar. Thank you, Professor Volker.
Okay, first of all, thanks all of you for this very good webinar we had today. It's a great pleasure for WFNR always to host these seminars. And let me also express my gratitude not only to the speakers, but also to the technicians, especially Christian and his team helping us to organize this, and especially also to Tracy, who always helps us very much to bring this about. To the audience, I think we are at the moment planning further webinars for the end of this year and for next year. And I just want to ask the audience eventually if they have interesting topics which they would like us to address in this series of webinars that could be helpful. Just contact me or Tracy. You find the emails on the WFNR website all the time so that we can eventually respond to any thematic suggestions which are coming up from the membership and from other people around. So at the end of this, thanks all of you very, very much indeed. I'm sorry I couldn't get in very much at the beginning. I'm sorry for causing a delay for whatever reason. There was some sort of a technical buzz in it. But nevertheless, I'm using Zoom almost 5 or 4 times a day, but sometimes there are some problems. So thanks all of you very, very much, and hope to see you soon. The latest, of course, in Vancouver, but eventually before in one of our other activities and the webinars. So thank you very much.
Bye.